you so much for joining me here on today's episode of the podcast. I have Dr. Ilana Gurevich here. She's a naturopathic physician and a fellow of the American Academy of Naturopathic Gastroenterology. Thanks for being here.
Thank you so much for having me.
Well, I'm so excited to get to know you a little bit more, hear more of your story. Can you tell me a little bit more about, why did you get started as a naturopathic physician? How did you get started?
So I had the misfortune of at the age of 12, I started dealing with chronic abdominal pain and GI stuff. And my parents are both physicians, and they took me to a lot of different doctors, primary care, gastroenterologists, internal medicine doctors, and nobody could figure out what was going wrong with me. And then at the age of 19, I went to see my fifth gastro at the time, and she was the first person that ever wanted to do a scope. And so she ran a colonoscopy on me, and they diagnosed me with Crohn's disease of the small intestine. She diagnosed me, she started me on pharmaceutical therapy, and within 7 days, I became hospitalized. And so they put me into the hospital. I was in a very significant flare. They couldn't get the flare under control. It was the 90s at that point, and there was not a lot of pharmaceutical options. And so I got started on high dose steroids. That was really my only option for treatment. And luckily, my father, who's a psychiatrist at the time, or he still is, but he was a psychiatrist, and he was going through his own midlife crisis. And, some men buy cars and have affairs. He was discovering alternative medicine. And he was a board certified addiction psychiatrist. I think he's triple board certified. And he had just discovered the use of 5-NP or acupuncture to work for addiction. And so him going into this realm of alternative medicine, he learned about a naturopathic physician in Connecticut who I went to go see 7 days after I got out of the hospital. And I remember I was this 19-year-old kid, and my dad was dabbling in alternative medicine. So I walked into the office with like one of those big pill holders, like the ones that 80-year-olds have, not the ones that like 40-year-olds have. And I was taking 19 supplements that he was just like researching. It was before the internet. So somebody told him this and that, and I was taking all of these pills. And the naturopath took away 2 bottles and replaced them with 4. And at that point, I was high on steroids. I was very emotional. I started crying hysterically. And the naturopath said, give me a year. 1 year of doing what I tell you, and you will be a different person. And I walked into his office as a 19-year-old. I was my height. I was 89 pounds. I was cachexic. I was tired. I was anemic. I couldn't eat. I was in chronic pain. And I remember a year later, I was living abroad in Scotland. I was like normal weight. I was like exercising and partying and living like a normal teenage life. And I realized I actually had this conversation with this very, very sick Crohn's patient in Scotland who had been on an elemental diet for 4 months, couldn't leave his house. And I realized that what I did working with Dr. Sensening, who's passed away, that naturopath who saved my life, this is what I'm supposed to be doing. And so that started my journey, not only into naturopathic medicine, which literally gave me life, but also into specializing in chronic gastrointestinal issues because it like that's why I'm alive. And so that's how I started doing what I've been doing. And I've been doing it for, I think I'm about to hit 18 years.
Yeah, that's amazing. A lot of times I feel like we pursue the careers or passions or purpose because we ourselves were what we needed at that time, right? And so I love that you're now kind of passing or kind of your naturopathic doctor kind of passed the baton to you, and now you're kind of spreading that to larger audiences, more people now have access to other options, right, that have been struggling. What would you say present day, most recently, has been something that has been changing or shifting in the industry? What would you say where are we trending towards now?
So okay, so inflammatory bowel disease is a subset of the population, very, very sick patients. And then more than that, that's probably like maybe 40 to 50% of my patient population. On top of that, there's a lot of IBS and chronic functional GI disorders, right? And so IBD has a set of tools where the pharmaceuticals can oftentimes, not always, but oftentimes bring the inflammatory portion of the disease into remission, right? But within the IBD, there's also this IBS subset, right? So with inflammatory bowel disease, we see these anatomical changes, and those anatomical organic changes then change the functional aspect of the digestive organs, right? It changes the microbiome composition. It changes the inflammatory composition. It changes the immunological composition. What's really interesting for my population is just because they're on the pharmaceuticals doesn't mean they're feeling good. Like I have patients coming in who are in a histological remission, and so the gastro is like, well, you're feeling fine. Like your numbers look fine. What are we doing? And that is when the IBS subset, you start working up these patients for the IBS within IBD, or, the other half of my population is just IBS within IBS. And you start trying to recognize and understand the underlying cause of their condition. And what is incredibly accurate and, answers a lot of questions is the functional testing in an IBD patient, and a Crohn's patient in particular, but there's also data on ulcerative colitis. I'm using a fair amount of breath testing or SIBO testing because when you have anatomical changes, you then have microbiome changes, and you need to try to figure out what is causing that microbiome changes so you can treat and bring them into not only a remission, which the drugs might do, but also into symptomatic response where they're not thinking about their GI all the time.
Absolutely. Well, I think you bring up such a valid point, or like a lot of times I feel like people come to you probably from traditional medicine saying, "Hey, my doctor's telling me that everything is fine. My labs are looking fine," but yet maybe they're still on the steroids, they're still on immunotherapies, and this is considered just that's what they think is normal, right? So tell me a little bit more about how maybe some of these breath tests that you're utilizing, or how are you kind of telling these patients that there's another way?
So breath tests are really, really easy to do, right? So one of the things you're always doing if you're in the functional space is it's easy to defer to like, oh, get a stool test, let's see what the stool is doing. And that's a good, useful technology, but not for a lot of your chronic IBS patients, because like a lot of the chronic IBS patients, the problem is not the small bowel, it's the large intestine. And the reality is there is a very, very distinct difference between the microbiome of the small bowel and the large bowel. The analogy that we always use is the small intestine, your small intestine has more in common with the small intestine of a mouse than it does with your own large intestine, right? The microbiome is distinctly different, and there is not a great way to sequence the microbiome of the small intestine unless you have them sedated with endoscopy and doing an aspirate. And even if you have them sedated with endoscopy and doing an aspirate, you're really only getting the first, I don't know, 6 to 12 inches of the small bowel and the last 6 to 12 inches of the small bowel. So you're missing all of that middle portion. So what we have is very, very old and actually very well validated technology using a Quintron breath machine that's been around for 20 plus years that has been tested rigorously. And what we know is when you introduce first, when you put the patient on some kind of fast, mainly taking away fiber for 1 to 2 days, and then you introduce a substrate, either glucose or lactulose, and both of them have their positives and negatives. And then you track that, you follow that substrate through the breath. So, you have them drink the substrate, collect a baseline breath sample, drink the substrate, and then run that test every 15 to 20 minutes for, X amount, 2 to 3 hours. Then you get to follow how that substrate turns on the bacteria that's in there. So it's an exceptionally accurate, very old, very well validated technology to show you exactly what type of fermentation is happening within the GI tract. And mainly what you're looking at is there a bacterial overgrowth that's going to come up with hydrogen? Or is there a methanogen overgrowth that's going to come up with methane? And patients really quite prefer collecting their breath than they do collecting their stool. It's a lot cleaner.
A lot cleaner. I mean, also, probably way, way easier than an endoscopy, colonoscopy, right? Like those are all like people avoid those necessary, right? But like, you know, something breath versus like a stool sample.
There's no sedation. I'm not sitting you on the toilet for 12 hours straight. It's a very accurate, very reliable test.
Right. Which that I think hearing that, why wouldn't people try it, right? Why wouldn't people decide this? How do I think that what we're facing is probably not enough knowledge that this probably exists, right? Or the differences between the small GI tract, the large GI tract, the small mid sections of our, like, there's just not enough education out there around it, right? What would you say has been maybe one of the most surprising, or maybe something that's been working really well within your practice, maybe what's been a little bit more frustrating?
Yeah, I mean, the way I define a healthy GI tract is you feel when you're hungry, you feel when you have to have a bowel movement, but you're not thinking about your GI tract outside of those things, right? That's how I think is a healthy GI tract. A lot of my population is thinking about their GI tract like a quarter, a half, three-quarters of the day. And that means that there's so much that they're not doing because their attention is getting turned to the GI tract. And a lot of these patients are coming in, for years and years trying to figure out what it is on their own. So maybe they're running a food intolerance test, like a blood IgE or IgG test, or maybe they're trying this detox or that supplement, and they're not getting better because they're not getting to the root of the problem, right? And so the problem with that, me as a clinician, is they're just stepping in to see me as a new patient, but they've been on this journey for months, years, sometimes decades, right? So they're fed up and they don't want to necessarily do figure out the underlying cause. In my experience, when I first started practicing, I used to do a lot of, it sounds like dot, dot, dot. So I'm going to give you dot, 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 right? And inevitably, what ended up happening is I made a lot of wrong dot, dot, dot choices. And then 3 months, 6 months, 9 months later, now I'm working them up for testing to try to figure underlying cause. And so what I've realized now at this point, and I've been at it a long time, at this point, my first visit, we always start with a testing. I'm going to take an intake. I'm going to figure out where it sounds like they're having the problem. If it sounds like they're having a problem within the small bowel, I'm going to start working it up with a breath test. If it sounds like they're having a problem in the large bowel and they're not having a lot of bloating, abdominal pain, especially periumbilical pain, a stool test, it makes perfect sense. But honestly, the biggest pain point that I have patients coming in, at least in the last 5 to 10 years, is they have a lot of pain and they have a lot of bloating, and that bloating they get uncomfortable with it. And so that's often where I'm going to start.
I think you're exactly right. I think so. We think that so many things will be solved by dot dot dot, but what we're not actually addressing is the root cause, right? We're not addressing, okay, well, where is this actually coming from? Where is, like, how do we solve for the bloating or the pain and the abdomen? And so I'm curious to know, like, your patient journey, right? They come to you, hey, I'm bloated. Talk to me about that.
One of the most frustrating patients to work with are the ones that come in and they've been dealing with this forever and they're down to 5 foods. You know what I mean? I have these 5 foods. They're generally pretty heavy in protein, and I'm afraid to introduce anything else. And I can't go out. I can't socialize. I can't do anything like that. So when a patient comes in, the first thing I'm going to do with my first intake is I'm going to say, okay, does this sound like it's upper GI, esophagus, stomach, right? Gastritis, esophagitis, heartburn, reflux, GERD, or maybe a ulcer-like presentation. So that's my first. Do you fall under that camp? Or do you fall into what I call the small bowel camp, right? The thing about the small bowel is if you have gas in your stomach, you belch, right? If you have gas in your large intestine, you fart. But your small intestine has a valve that separates the stomach from the small bowel and a valve that separates the small bowel from the large bowel. So if you have gas in your small intestine, there's no place for it to go and you bloat. The typical SIBO bloating presentation is going to be you generally wake up flat or flat, your abdomen is flat in the beginning of the day, and then it continues to build gas as the day goes on, and you get more and more and more bloated. So by the end of your day, you're usually wearing elastic pants or no pants at all because something that's fitted doesn't fit anymore. That is a key diagnostic pattern to say, I want to work up the middle bowel, right? And so if that's happening, then it's like a no-brainer. Okay, I know what I'm dealing with. There is sometimes a confusing picture where, like, one of my residents just had a patient yesterday who was diagnosed with microscopic colitis. That's a large bowel disorder, right? There's inflammation of the microscopic inflammation of the large bowel, but she also had this bloating picture. And sometimes there you have more than one thing going on. You've got a small intestine bloating abdominal pain picture going on, which makes me think, okay, there's probably a SIBO component. And then you also have a large bowel microbiome, microscopic inflammation pattern going on. And so with those patients, I am more likely to start up and work my way down. Because if the small bowel isn't doing its very large, very significant role in digestion, obviously the large bowel isn't going to be able to do its role of digestion, right? And that happens a lot with a chronic IBS population. So the way I do an intake, I'm always going to see what's presenting, and that's the area of the GI I'm going to work up.
Mm. Okay, amazing, amazing. And that's really helpful to know because I think in this day and age, some people go to see their gastroenterologist and all they get is 7, 10, 13 minutes if they're lucky, right? Whereas, I think in like allopathic, functional health, naturopathic medicine, well, you're able to really get to that root cause and really get to like the backstory, the background, and like what are you actually dealing with, right? What would you say is maybe like on the horizon, 6 months, 12 months, couple years from now? What's the ultimate vision or goal?
The amazing thing about the functional medicine, naturopathic medicine space is we are cutting edge, right? Like, I'll give you an example. Things that I was finding super interesting in 2002, 2003 when I was in school, so 22, 23 years ago, is just now starting to drip into the conventional world, right? Because they are so slow to uptake new technology, which is good and bad. It's good because they're not going to do as much harm because all their technology is going to be very well validated. But it's bad because, with AI learning, we're just learning so many new tools. And so a lot of patients are falling through the very large cracks that exist in the conventional model. What is exciting for me on the horizon is all of these new technologies that are right now being born and being tested out in labs that are going to get introduced within the functional medicine space to patients so we can get even more understanding of what is the root underlying cause. So that to me, I can't wait. That's what keeps my job continually exciting.
That is super, super exciting. And I agree with you. I think there's so much potential in the space of functional health and things that we just have not seen, and it's just growing super rapidly. And then, is there a certain type of breath test that you utilize? Where do you turn to for that?
So Quintron is
Quintron.
the
Mhm.
king of the castle, right? Quintron is the technology that makes the machines. I've played around with a lot. I've been at this. I was starting to treat SIBO back in 2013. So I've been at this a long time. I've played around with all of the tests, and 15 years later, I guess not, I guess it's more like 13 years later, I am still convinced that Quintron is the technology that's been validated. So All Clear is the company that I've partnered with. They run tests. The All Clear, first of all, is by far at the moment the most affordable test on the market. It's somewhere between 25 to 50% cheaper than any other test. And then All Clear also is the fastest. So they're turning around lab samples. When you're doing other tests, you're waiting 1 week, 2 weeks, 3 weeks. They're turnaround tests in 24 hours from when they receive the test kit, which is really very useful. And, they exclusively use the Quintron machine. That's the best validated machine out there that has the historical benefit. And so I'm using them mainly because I find them accurate, rapid, and affordable. And they also offer a lot of support for clinicians. They have a lot of really interesting clinical protocols that, we share through our knowledge of doing this for a long time. And then if you're looking to a little bit, make a business model that works for patients, they also have business strategies that they offer to patients. And so that is the company that I'm partnering with.
Amazing. Well, thank you so much for sharing that. And how can also people find you if they're curious to learn more information about whether it be all clear or working with Dr. Ilana, how can people reach you?
So if you're a clinician, you're wondering about All Clear, they have a really useful website to link to. It's client success at allclearhealthcare.com. So that's really easy. You can send them an email. They'll send you all of their information. Everything's really well put together. It's a business that runs very smoothly. You can find me at Open Wellness, which is the clinic that I run in Portland, Oregon, and I am licensed in California, Oregon, and Washington. So I treat patients in those three states.
Amazing. Well, thank you so much for joining me here. It's been such a pleasure to get to know you a little bit more, as well as learn more about the gastro, SIBO, IBS space, all of the things. I really look forward to hearing what our audience and listeners have to say about today's show.
Thank you, Rachel. I really enjoyed talking to you.